Good morning and welcome. We're going to get started here. Just want to make sure I've got my speaker on, you all can hear me. Welcome to ICD-10-CM coding training for 2022. There we go. My name is Alicia Coons, and I am a certified coding specialist with Anderson Health Information Systems. I know quite a few of you have attended our in-person training, and at some point we'll get back to that, but right now we're just going to do the best we can virtually, and let's get started. Of course, here we have our generalized disclaimer. None of this is going to be intended as legal advice or anything pertaining to a particular situation. So just go ahead and take a peek at that, and let's get started. So our objectives for today are obviously to learn how to go through physician documentation so that you can ascertain what your principal diagnosis is. When it comes to PDPM for Medicare Part A's, you want to make sure that you have a principal diagnoses that will map you into a clinical category so you can get properly reimbursed. We're going to go over changes to the official coding guidelines and some coding changes that we do have for this year that were effective on October 1st of 2021. We're going to briefly touch on physician queries, when you should do a query, some rules about writing queries, and then of course we're going to go over some common coding errors that we do see in our daily consulting. First thing we're going to do is make sure that we have our coding books next to us. The picture you see on your screen here is for the Optum ICD-10-CM expert for skilled nursing facilities. Any of the ones that are ICD-10-CM will work, whether it's for nursing facilities or hospitals. This is just the most specific one for our particular industry. Just be aware that every year you will need a new code book. So on October 1st, you're going to need a new one. You'll probably start getting phone calls from book vendors, reminding you that you need to order a new book. So make sure that you're budgeting for that. That's really important. And make sure you're saving your old book for a few months, just in case you have to look back on some claims on maybe some codes that have changed. So we're just going to briefly go over the sections of the book. So the very front of your book, you're going to see the official guidelines for coding and reporting. And usually the side of the page that runs along the spine, you'll see is black. And they also have sections at the beginning of each chapter, which is broken down by body systems that are highlighted in purple. The next section you're going to see is your index to diseases and injuries, and that is in gray. And this is where you're going to always look up your codes. Sometimes I'll refer to it as the alphabetic index. That's generally how I'm going to refer to it throughout this presentation. And this is where you're going to start and look for any codes. Consider it like your glossary or your dictionary. You start at the front of the book, and then once you get a baseline code or a default code, you then go to the tabular, the back of the book, to verify your codes. Then you'll have within that section some more black pages. Those are the ICD-10 neoplasm table. This is where you look up your or cancer. Some of those will be benign. Of course, then you have ones that are malignant. So any tumor, you're going to start looking up there. And your neoplasm table will have 2 columns per page with body sites that are alphabetical, and those are running vertically down the page. And then, of course, the behavior of that neoplasm or tumor will be horizontally across the top of the page, whether it be a malignant primary neoplasm, malignant secondary, or benign, etc. And on your screen here, you'll see how that looks. You can see going vertically down the page, you've got pharynx, and then portions of the pharynx, fornix, recess, etc., pia mater. And then across the top, you'll see malignant primary, malignant secondary, cancer in situ, benign, neoplasm of uncertain behavior, or neoplasm of unspecified behavior. So when you see uncertain behavior, that's not that you as the coder are uncertain as to what type of neoplasm it is. It's that perhaps we don't know yet what the neoplasm is. And sometimes you'll have a situation where you'll have a resident come in, they've removed some sort of tumor, and they are still doing a biopsy. We don't know yet at this point what it is. So that would be perhaps a time you would want to use the uncertain behavior code. And then the next section within the front of the book is gray. It's just past the neoplasm table, and this is your table of drugs and chemicals. And similar to the table of neoplasms, your drugs are listed alphabetically going vertically down the page, and then across the top you'll have poisoning, adverse effects, underdosing, etc. And all of these codes you do need to verify in the back of the book. That includes the table of neoplasms and the table of drugs and chemicals. So this is how that looks. You'll see your substances going vertically down the page, and on top I can't say that, I'm so sorry, going horizontally across the top of the page, you'll see the behavior or what's going on. So for instance, you'll see poisoning accidental. So somebody's taken something accidentally, maybe the pills look the same, that would be one you would use. Poisoning intentional, self-harm, poisoning assault, poisoning undetermined, adverse effects, which probably is the most common one you're going to use, and then underdosing. And keep in mind, a lot of these are going to be under the generic name. So for instance, if somebody has taken too much Tylenol, you would look that up under acetaminophen, something along those lines. So just remember, if you can't find it by one name, you'll probably just need to do a quick Google search to find out what the generic name is in order to look that up in the table of drugs and chemicals. Then you have a whole section that's in black, and that's the index to external causes. So this whole section is external causes of morbidity or injury. Again, those are alphabetically. These are statistical codes. So in acute hospitals, they are required, in California anyway, to use these codes and submit them for statistical research. If you ever wonder where insurance companies get that information, like, statistical data on injuries, these codes go a long way towards doing that. So just know we are not required to submit these codes. And you'll see these a lot of times that are part of the documentation within the acute hospital record. You don't need to copy these over. So just remember, not necessary. It's not a big deal if you did, but again, unnecessary. Now, remember I was saying the beginning of the book, the alphabetic index is where you start looking up a code, and it'll give you a code, and then you then have to go to the back of the book, which is the tabular. And these are the rainbow pages. They're all different colors. Each chapter is going to be a different color. This is where you're going to look them up. So this is the back of the book. And there's 21 different chapters for different body systems. And again, they're all color coded. So you verify the code that you find in the front, you take it to the back, and you read the chapter guidelines and the instructional notes to get your code. So code structure. All codes are a minimum of 3 codes. So if you ever see a code less than 3, that's not valid. You have some that are only 3. For instance, G20 is for Parkinson's disease, and that is a totally valid code. And then you have them all the way up to 7 characters. So you can see they're 3 to 7 characters long. Your first character will always be a letter. Your second character will always be a number. And then any of the characters between 3 and 7 can be letters or numbers. The decimal is always going to be after the third character. So remember, I was talking about Parkinson's disease. That's only 3 characters long. You don't need to put a decimal after that. The decimal is only used for codes that are more than 3 characters long. Some ICD-10 codes have your 7th characters, and that must always be in the 7th character field. And you will see that within your coding book. If you're using Optum, a light pink box that will tell you what the encounter is. And this is what that looks like in the Optum book. There are other publishers. Some of them are in gray. It just really depends, but Optum is the one that we are using for this presentation, and that's the code book that I generally use. So you can see here for open wound of the head, it's telling you the appropriate 7th character is to be added to each code from this category S01. So if it was an initial encounter, that's usually hospitalization, the letter would be A. But if they're with you in post-acute care, it would most likely be D for subsequent. And then we also have sequela, and in a few slides, I'll probably be going over what sequela is. So again, A is your initial encounter. Think A for active treatment. And this is generally for your purposes. If you have a resident who gets injured and we don't send them out to the hospital, we're going to deal with it all in-house, we would use A. So the best example that I know that I like to use is one of my facilities had a resident who had pain in their shoulder, and they didn't send them out. They had a portable x-ray come in, take their x-ray, and determine that they had a fracture of the clavicle. You're not going to cast that or do anything for that. The physician just prescribed a sling, so they kept him in a sling, and we're just very careful not to, yank them by that arm or hurt that shoulder. So in that case, they were able to code the clavicle fracture with the letter A for initial encounter or active treatment, because they were the only ones who were going to be providing treatment to that resident. However, let's say you have a resident who has a femur fracture. Maybe they fall at your facility and they fracture their femur. That's not something we're going to treat in-house. We're going to send them out to the hospital, and when they come back, it will be that femur fracture code with the 7th character of D for subsequent encounter. This is for the healing phase, which is what we would be dealing with. And then S is for sequela, and that's a late effect. So if you're using any code with an S at the end of it, that means that they have some sort of late effect as a result of that injury. So very rarely are you going to see that. So just remember that you don't want to use an injury code with the 7th character of S unless they have some sort of late effect of that injury. And also, when it comes to sequencing sequela, you have to code the sequela itself first, followed by the condition that caused the sequela. And before I go a little further here with 7th characters, think of, when we're talking about that sequela, think about somebody, and this may pop up in a couple more slides as well, but while I'm thinking about it, if you fracture your cervical vertebra right up here in your neck, and you have paraplegia or some sort of injury as a result of that, then in that case, you would code the paraplegia first, followed by the code for the cervical spine injury with an S for sequela. One of the things that we want to caution you about is not to copy codes from the hospital record. One, the coders at the hospital are human, just like you and I, and they can make mistakes. You want to code based on the documentation of what the physician is actually writing, not the codes that they may or may not put on in the documentation. So also remember, when it comes to an injury and the hospital's treating that injury, the hospital is going to use the 7th character A, which is not something that we would normally use. So just be aware of that. We also have a placeholder X. And these are for, you'll see these within certain codes. And the reason for that is to allow for future code expansion. So where a placeholder exists, you have to use the letter X to fill that in. And here's an example. So if you have a code that's less than 6 characters, and you'll see that little pink box, it says you have to use a 7th character, you need a placeholder. So for example, if you were to go to the alphabetic index in your book and look up contusion of the scalp, the default code that you're going to see there is S00.03. You then need to take that code and go into the back of the book, the rainbow pages, and go to S00.03. And there you'll see the pink box. It's telling you you have to use a 7th character. So as you can see here, the finished code is S00.03XD. And the reason we had to put that letter X there in the 6th place is so that the letter D, which is required for this to be a valid code, is in the 7th spot. Some abbreviations that you should be aware of are NEC, not elsewhere classified. This means that perhaps the physician has given you some information about a specific condition, but there is not a specific code for that condition. So this NEC represents the concept of other specified. So here's an example, D64.89 other specified anemia. And that would mean, if you're using this, that your physician has told you it's some sort of anemia for which we don't have an existing code. NOS is not otherwise specified. And you're going to, when you think of this, just think it's an unspecified code. So if your doctor says that your resident has dementia, but they don't tell you what type of dementia, just dementia, your default code will be F03.90, unspecified dementia without behavioral disturbance, or dementia NOS, not otherwise specified. Other codes, so if you see codes that have the words other or other specified, you will use these when the information within the medical record provides detail, again, for which that specific code doesn't exist. And then again, unspecified, meaning we just don't have enough information to assign a better code, a more specific code. Includes notes will further define or give examples of the content. And a lot of times you're going to see a list of terms that are included within a code. They're not going to be exhaustive, but it'll give you the main ones. Excludes notes. We have 2 types of excludes notes. Excludes 1 means not coded here. That means that the code that we are supposed to be excluding can never be used at the same time as the code you're using. So a lot of times you'll see these with codes that can occur together. So congenital versus an acquired form of the same condition, because it's one or the other. And there's an exception, is if the 2 conditions are unrelated to each other, then you may need to query the physician. Excludes 2 means it's not included here. But if they do happen to have both conditions, then it is acceptable to use both the code and the excluded code together when appropriate. So here's an example of an excludes 1 and an excludes 2. J01 is the code for acute sinusitis. So there is an excludes 1 code saying do not use sinusitis not otherwise specified, J32.9, at the same time as J01 acute sinusitis. So the reason for this one, the rationale for this, is that acute sinusitis is a specific diagnosis and it's a specific code, but sinusitis NOS is unspecified. So if you have documentation of acute sinusitis, that's the code you're going to use. You don't need to also then use an not otherwise specified code, because that would be contradictory. And then excludes 2 for chronic sinusitis. And the reason for that is, if you think about it, people who have sinusitis a lot of times have it chronically, and then they'll have acute flare-ups. So sometimes you can have both at the same time. Then we have etiology and manifestation codes. So that's going to be, you'll see the instructional notes for code first, use additional code, or in diseases classified elsewhere. So when you see the term use additional code, that you're going to see that at the etiology code, and then the manifestation code will tell you to code first the etiology. And it's going to tell you how to sequence those. And basically, it's always going to be etiology followed by the manifestation. So here's an example: dementia in Parkinson's disease. The underlying cause of that dementia is the Parkinson's disease. So therefore, it's always going to tell you to sequence the cause first. So Parkinson's would come first, and then it's telling you to use a dementia code from category F02. So that is dementia in other diseases or diseases classified elsewhere. We also have instructional notes for, you're going to see the terms and or with. So if you see the term and, it means either, and or. And if you see the term with, consider that to be associated with or due to. So that means your classification is assuming a cause and effect relationship between the two conditions that are linked with the terms and or with. And you're going to code them as being related. So if there's combo codes, you're going to use those. You don't need the physician to explicitly link them. Codes that are linked with those terms. So these are your main ones. Dementia, diabetes. So if you look up your diabetes codes, there's going to be a whole bunch of codes that are connected. Diabetes with chronic kidney disease, diabetes with foot ulcer, diabetes with neuropathy. Those are conditions that are presumed to be related. The same thing with dementia or anemia and hypertension. And when we get into the section about most common coding errors, you will see that diabetes and hypertension combo codes are the ones that are most commonly miscoded. You'll also see the term see or see also, and this can be frustrating. This is when you go to look up a code and it's not where you would expect it. For instance, you want to look up the code for Alzheimer's disease. You would think, okay, alphabetically, I'm going to go to A for Alzheimer's. But when you get there, it's going to tell you C disease, comma, Alzheimer's. And then you have to page forward to the D section to look up disease and then Alzheimer's. So that can be frustrating when you see it, can feel like a runaround. And then code also. This is why it's so important for you to use the code book. If you just Google a code, it's not going to give you the instructions for additional codes that you may need. And sometimes when you go to a code, it'll give you a code and then it'll say code also something else. And one of the best examples I can give you that is, for instance, if somebody has chronic kidney disease and hypertension, it's going to give you a combo code for the two of them, but it's also going to tell you code also the chronic kidney disease. So if you hadn't looked in your book or read these instructional notes, you would have no idea, and it would be incorrect. The principal diagnoses. So we need to be aware of what is the principal diagnoses. And the definition, according to the Uniform Hospital Discharge Data Set, is the condition established after study to be chiefly responsible for the admission of the patient to the hospital, or in our case, long-term care, for care. So you need to think about that. And coding, sometimes, we think, oh, it's not that difficult, I can Google it. It really does require critical thinking skills. You have to think, why were they admitted to the hospital? And then consequently, why are they then coming to my facility for care? So it's not always terribly obvious. So it does require some thinking. Within this presentation, you'll see the terms principal diagnoses, primary diagnoses. I'm going to use them interchangeably a lot of times. Mainly what I will use is principal diagnoses, But in the ICD-10 coding guidelines, they use the term principal diagnoses. And again, that's the condition established after study to be mostly responsible for the admission. But the RAI manual, in particular box or line item I0200B, that is the primary diagnosis. And that is the resident's primary reason that they're coming in for a Medicare Part A stay. You will see this box or this section on the MDS for the 5-day for your Medicare A's and for your interim payment assessment. What codes should we code? What shouldn't we code? I'm sure you probably all know this, but I have to mention it. You want to be careful that we're not coding possibles or probables or questionable. Oftentimes you're going to see this when, let's say, the resident goes to the ER, and in the ER, a lot of times they're going to have differential diagnoses. They're going to have, it could be this, it could be that. If you want to make sure that you're looking through all the documentation to make sure that by the time they come to you, we have some sort of definitive diagnoses. So you want to be careful about that. If in the discharge summary, however, they say it's this versus this, then you can code both of them. But again, that's usually not the case. Resolved diagnoses should not be coded. So sometimes I think what happens is, we're in a hurry, we're trying to write up these diagnoses lists, so we're going through and we're just writing them down. We're just writing them down and we're coding them. But if you're reading it, a lot of times it'll tell you. For instance, one I see often is acute kidney injury. Maybe they go in, they're dehydrated, they have some sort of issue with their kidneys, and their diagnosis AKI, acute kidney injury. But usually if you look on the discharge summary, it's going to tell you that it's resolved by the time they left to go to you. So just be careful that what you're coding is something that is active once they've come to you. So here's an example of coding a resolved diagnosis. The resident has, or I should say the patient, has cholecystitis. They go to the hospital. They go in, they've got, abdominal pain. They've determined they have cholecystitis, and the hospital treats them with a cholecystectomy. They remove the gallbladder. They then come to you at your SNF for further care. Cholecystitis is no longer an issue once they've come to you because they have resolved that condition by removing the gallbladder. We are not treating the cholecystitis anymore. It's no longer existing. But what we are treating is the aftercare. We're taking care of, their surgical site, all that business. So remember, in this particular case, we would use Encounter for surgical aftercare following surgery on the digestive system. And then we would also have a code that kind of helps us out, a helper code, so to speak, of Z9049, acquired absence of other specified parts of the digestive tract. So one of the things that sometimes happens is you have a resident who comes in. Their reason for their admission to the acute is clearly resolved, and we're no longer treating that condition, and we're just not sure what to do or how to code it. The best practice is for your IDT to get together and discuss why are they here. If we still are unsure, we need more guidance from the physician, we would use a query to talk to our physicians and get more clarification. And in the packet of materials that you were provided today is a query here for undetermined principal diagnoses. Now remember, query tools, we only want to fill out the top portion where we're asking for more information. We want to leave the bottom portion that's designed for the physician blank and give that to our doctors so that they can fill that out and give us more information so that we're able to code appropriately. And then all queries get filed within the medical record. That's very important because that is your supporting documentation. Every code must have supporting documentation for all codes assigned, but mainly your Medicare A's, you really want to be careful with that. So let's talk about the steps to finding a code. Your first step, step one, you're always going to look up the main term in the alphabetic index. Remember, those are the gray pages at the front of your book. Then once you get that code, you're going to verify it in the tabular and get it to the highest specificity that you can find. And then just make sure that you always, again, verify on the tabular, because it's going to tell you the length of the code you need. And then your excludes notes, your code also codes. Again, very important to use your book. Then you want to review your chapter specific coding guidelines. And we're going to practice. So go ahead and get your coding books out. If you don't have the most current one, it's okay. You can still use whatever code book you have to practice. We're going to be doing some scenarios today. The one we're going to do right now is not an actual coding scenario. It's just practice for how to look up a code. But just be aware, we will be doing some coding scenarios today where you are able to practice looking up the codes, and then they'll be a little bit interactive. You'll be able to select on the screen the codes that you've selected, and we'll have an idea of where you all are. And again, don't be nervous about that. This is an opportunity for you to practice and also to have an idea of where everyone's at. Again, I don't know who specifically is clicking on what, so it's all anonymous, but it's fun. You can kind of get an idea of what other people are thinking about your coding scenarios. But let's practice. We're going to look up the term congestive heart failure. So you have three terms here, and you have to determine which one do I think is the main term. And in this case, it's going to be the term failure. So you go to the front of your book and you're going to look up the term failure, and you're going to see it in bold. Then you're going to look for the subterm heart, and then the subterm below that will be congestive. So this is what it will look like. You'll see failure or failed in bold. And then the next one is heart. And you can see vertically going down from the term heart is a gray line. And then there's another gray line. So think of those gray lines as your placeholders. There's other types of failure. You can look up kidney failure, or any number of failure, liver failure, but we're looking up heart. So then you have failure, heart, and then your next indent in is the word congestive, and your default code is I50.9. So if you know more and you want to look up more, you would keep going. Is it diastolic? Is it systolic? Is it acute? Is it chronic? Is it acute on chronic? So you can find your most specific. Again, keep searching for the level of specificity that you may need depending on what your physician has told you. Then you would go to your tabular or your colored pages, and you would read the instructional notes. The alphabetic index does not always provide the full code. You can never code just from the alphabetic index. And again, you want to make sure that you are reading your notes. Sometimes in the alphabetic index, you'll see a little dash, and that dash will tell you that there's more to that code, but it's not always going to be like that. So you want to be really careful that you are checking that. Okay, so again, we were looking up heart failure, and you can see here on the screen that there are some excludes notes in red. It'll tell you code first. Heart failure due to hypertension, or heart failure due to hypertension with chronic kidney disease. There's an excludes one for neonatal cardiac failure, and that means that you cannot code regular heart failure with neonatal cardiac failure. They don't go together. But there is an excludes 2 note for cardiac arrest, which means if they have CHF and they had a cardiac arrest, you could code the 2 together. So let's get into the PDPM overview, patient-driven payment model. And that was the one that came out a couple of years ago that changed how we bill and for Medicare Part A. So again, they shifted the focus. The focus used to be on therapy, But what they've done is they've shifted the focus back to the resident's clinical needs. So ICD-10 codes are going to be part of your reimbursement rate. There are coding edits based on correct coding practice, and which means, are you coding according to the coding guidelines? Very important. Medicare insists upon that. And also, do you have supporting MD documentation? So this is why I was saying earlier, if you have a resident where you're not sure about the principal diagnoses and you have to query the physician, that you have the physician sign that, and it becomes part of your medical record to support the use of that code, whatever code you're based on whatever your physician is documenting. You want to be very careful. Ignoring your coding guidelines can make you a focus of review by Medicare. And if they're, finding issues, they can reduce your reimbursement. So you want to be careful. So we have six case mixes as components that make up the resident's total rate. You've got your physical therapy, your occupational therapy, speech and language pathology, your nursing component, and your NTA, non-therapy ancillary. And then you also have something called non-case mix. That's something you can't control. The non-case mix has to do with whether you are rural or, in a city, that sort of thing. So that's something you can't control, but the other five you can. So the rate adjusts, your per diem adjusts over the course of your resident stay. So your PT, OT component, it decreases by 2% every week after day 21. And your non-therapy ancillary component, you get triple reimbursement for the first 3 days, and then it evens out the rest of the stay. This is why, especially if if I'm your consultant, when I'm in your building, I'm always searching to make sure that we're capturing all of our NTA components, because again, that triples your reimbursement. Very important. And then your nursing component is going to stay the same the entire stay. So one way in which we use codes under PDPM, we have to report the principal diagnoses on our MDS on line item I0020B. And that code is mapped to one of 10 PDPM clinical categories, which then help with our therapy components. So when we are assigning a principal diagnosis, it has to be accurate, and it has to be one that maps into a clinical category, that it is not a return to provider code. If you get a return to provider code and you try to submit that as your principal diagnosis on your MDS, on your claim, you won't get paid for it. So it's very, very important. You can look up your clinical category mapping tool on the cms.gov website. And it's an Excel file. Do not, whatever you do, don't print it. It's hundreds and like 700, 800. It's a lot of pages. Don't print it. But it's a zip file. You can save it. A lot of times though, just, I'm sure you all know this, it's built into your software. So I know, for instance, PCC and other ones, it will tell you if it's a return to provider code. But when you open up that zip file, you're going to see tabs at the bottom of the page, and you're going to see a sheet that is clinical categories by diagnoses. You would click on that and you would do Control F, type in your principal diagnoses without the decimal, and then press enter, and it will tell you what clinical category it maps into, or if it's a return to provider code. So this is what that looks like. You can see the big yellow arrows. So your ICD-10 codes is in this column, and then right next to it to the right is the code description, and then to the right of that is the clinical category. So this is how you would do Control F. That would open the search box. You type in your code without the period, without the decimal, and the one I've typed in here is I69320. Then you click enter or find next, and it will pop up. And that code, I69320, is for aphasia following cerebral infarction, and that maps to acute neurologic. This tells me that this code can be used as a principal diagnosis. So on your MDS, your 5-day, you're going to see box I0020. That's going to be the category, you have to click the appropriate medical category. And then on box I0020B, you enter the correlating ICD-10 code. Again, this is only on your 5 days or your IPA MDS assessments. And the category you check must correlate with the code entered. It should have some, resemblance there. For instance, for that code, the I-69320, your category for that would be stroke 01, stroke, and then your code would, the I-69320 would go down here under I0020B. So for our principal diagnoses, per the RAI manual, the instruction is that we are only going to code active diagnoses. Again, don't code anything that's resolved, doesn't impact our residents' current status, or drive their care during that 7-day look-back period. The definition of an active diagnosis in our RAI manual is a physician-documented diagnosis, very important, in the last 60 days that have a direct relationship to the resident's current functional status, cognitive status, mood or behavior, medical treatments, etc. So just be careful about that. One of the best practices that you should be doing is reviewing your medical record the day after admission, your IDT, and that together to determine what is the principal diagnosis. Does it map to a clinical category? That's important. And making sure that your therapists and your nurses know what your principal diagnosis is and any skill diagnoses right after admission so that the therapy evals are using the correct code, the correct medical code, and that the nurses know what to document on their daily skill charting. That's really important. If you wait, or if you let therapy sort of assign a code, you run the risk of using the wrong code. Maybe it doesn't map correctly. Maybe we're not using the right coding guidelines to support that code. You just want to be very careful. Best bet would be having everyone get together and forming a consensus what the best code is. Again, remember some use codes for PDPM is those NTA comorbidities and SLP comorbidities. So for your NTA comorbidities, this is a list of NTA comorbidities. You can see your diagnoses on the left. Yes, item set in the center section here, and then the number of NTA points. The more points, the higher your reimbursement. These are some SLP related comorbidities. So you can see the ones in bold have to be on section I-8000 of your MDS, which is your other active diagnosis section. And your nursing component has to do with nursing groups from extensive services to special care high, special care low, etc. And they are hierarchical. So it will map you automatically into the highest group that applies to the resident. And some of these categories require coding of diagnoses in section I, such as pneumonia, diabetes, COPD, etc. Unspecified codes, you are instructed throughout the coding book to code to the highest level of specificity that your physician is documenting. You don't want to use codes that are unspecified if you have information that will let you assign a more specific code. I will caution you, the biggest boo-boo you can make is to code when it comes to laterality, that you code unspecified. If you don't know if it was the right femur or the left femur and we're coding unspecified femur, that's a problem. And of course, that's why it's returned to provider. So be careful with those unspecified laterality codes. For the MDS, there's a section J on the MDS, and that's where you're going to enter the information about major surgery. And just know that you need to have the surgical reports in a lot of cases so that you're able to code accurately. And this is what that looks like. So you can see We've got a section here for major joint replacement, spinal surgery, orthopedic surgery, etc. For this section, you want to be careful coding, because if you're not coding to the highest level of specificity by what is documented, and that particular medical record is brought up for review, that'll be a problem because you're not following the documentation in the record. So again, supporting documentation, or if you're not coding it appropriately. So just be really careful. Lead to loss of revenue. For Medicare A, when you're coding, you want to think, is this a clear picture? Are the codes I'm submitting supported by clinical documentation? And do they show that this resident needs skilled care? That's what's important. So just know for Medicare, what your coding has to be for services that are needed for a condition that was treated while they were in the hospital during that qualifying stay, or for a condition which cropped up while they were in your care for which they were previously treated in a hospital. And when you're doing your Medicare meetings, you have to validate each code that it's consistent with the documentation and with the MDS. So make sure that when you're doing your Medicare meetings that you have those medical records there with you. For coding changes, this is just some links for the updates for ICD-10-CM for fiscal year 2022 and the coding guidelines. There's some links there. And official coding and guideline changes. This is something interesting. They put this in the guidelines. They said, a joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. We know this. We know that if they're giving us, garbage documentation, then the codes are going to be garbage too, right? Maybe that's not the right word, but, unspecified. So it's important, obviously, enough that they put that within the coding guidelines. So again, we can't overemphasize the importance of good documentation. If we don't have good documentation, we can't code appropriately. But also remember that we have tools to help us get good documentation. We have query tools. So there, when we do our QA meetings, we can discuss with our physicians about accurate documentation as well. So there's tools that we have to help us with that. We had some changes here for fiscal year 2022 for coding guideline changes regarding laterality, meaning right or left. So if our patient's provider doesn't tell us, and let's say somebody comes in and they had a right femur fracture, but our physician just wrote femur fracture on our H&P, we can look through the documentation from the hospital, from other clinicians, other doctors, that tells us it's on the right-hand side, and we can use that documentation to support the use of a code femur fracture. But if it's conflicting, then we need for clarification. And again, try not to use unspecified laterality if you can avoid it. So the codes that were assigned are based on physician or physician extender documentation. There are some exceptions. For instance, BMI. We can get the documentation for the body mass index from our registered dietitian. Pressure ulcers or other chronic non-pressure ulcers, we can get that documentation about the severity level or the stage from our treatment nurses. There's some other information here, coma scale, NIH stroke scale, social determinants of health, that's a section we'll touch on later, lateral alcohol level. But just remember the associated diagnoses. For instance, for body mass index, for that code, or we use that code with obesity codes. So we don't just willy-nilly assign a code for BMI. If the resident has documented obesity from the physician, the code for obesity asks us then for a BMI code to support that. So what we've done so far is we've sort of covered the rules for coding, how to look up a code, the importance of supporting documentation. Now we're going to go chapter by chapter over coding changes and things that are important. So we're going to start off with infectious and parasitic diseases. These are your codes from A00 to B99. This is where you're going to find all your infections. So I always like to go over what sort of infection codes we have. There are two basic sort of infection codes. The first one would be a combination code, and that would include your infection and the causal organism together. So for example, we have here J15.1, pneumonia due to Pseudomonas. And the second type is your standalone infection code, meaning it's just an infection without the causal organism. So for example, we have N39.0, urinary tract infection, site not specified. Anytime you see a code where it's a standalone infection code, it will ask you to code also the causal organism from section B95 to B97. They're going to ask you for an additional code for that. Now, one of the things when I'm looking through coding at a facility is, okay, I see we've got an infection code. Do they have an additional code for the causal organism? No. Okay, I don't see that. So what am I going to do? I'm going to then go to the lab section in the medical record, and I'm going to look. Do we have any sort of documentation, a culture and sensitivity that would tell us what the causal organism is? If not, okay, then I'm going to go and I'm going to double check that physician documentation. Sometimes I'll mention it there. Maybe we don't have the lab. If we don't have the information though, and we're using an unspecified code for the causal organism, we don't have anything, and we don't have documentation, well, at least we've done our due diligence. We've looked, to see if there is that documentation. So just keep this in mind. If we have the documentation to tell us what the organism is, if there is a existing combo code that includes the infection plus the organism, use that. If not, if it's a standalone code, then you will need a secondary code from section B95 to B97 to identify what the causal organism is. Some notes about isolation or quarantine, which I'm sure we're seeing with COVID. There is a section, a checkbox for this on the MDS, and it's O0100M2, isolation or quarantine for active infectious disease while a resident. We would need to check that off on the MDS, and then we would need to code the reason for the isolation, whether it's COVID-19 or whatever it is. We would need to code that on our diagnoses list. For sepsis or septicemia, and we use those terms interchangeably, this is a checkbox on the MDS, I2100, but for the diagnoses list, we would need to use the appropriate sepsis code. If we know the organism, so for example, if we know that it is sepsis due to E. coli, then we would assign code A4151. If all we know is that they have sepsis, but we have no further information as to the causal organism, then we would use A41.9. And just know both of those codes map to a clinical category. For HIV infections, just know that this is an NTA comorbidity worth 8 points. So, and in addition to it being an NTA comorbidity with the highest number of points, so your reimbursement increases for that, we also should know that it leads to an 18% add-on to our nursing payment component, and that stays the same throughout the entire claim. And this would be coded on the UBO4. We want to only code confirmed cases of HIV. Doesn't mean we have to have the blood test. We just have to have physician documentation of that. And we would use code B20 for that. So if we have somebody who has a history of HIV and we are managing it with antiretroviral medications, you want to code the HIV, the B20, and you can also use code Z79.899 to identify their use of antiretroviral medications. This code, the Z79899, would not be sequenced high. This would be towards the end of your diagnoses list. Just be aware, in California, we do have some rules when it comes to coding HIV. In California, the test itself, the results, that is what is protected. So we have to have signed consent for each disclosure of an HIV test result. It's a little bit confusing, but if you just remember to not use code Z21, asymptomatic HIV infection status, or R75, inconclusive lab evidence of HIV. Don't use those codes in California, period. Each unauthorized disclosure of the HIV test result can cost you $2,500. So just be careful about that. If somebody does have HIV, but you can use code B20. For infections or necrosis, we have some that will get you more NTA points. So if somebody has an opportunistic infection, that can garner you an extra 2 points. Bone, joint, or muscle infection will also garner you an extra 2 points. Aseptic necrosis of bones, 1 point, and so on and so forth. You can see here, there's a few. Resistance to antimicrobial drugs. You want to make sure that if you have somebody who has some sort of resistance, that you're assigning a code from category Z16. And one of the examples here is Z1612 for ESBL, extended spectrum B lactamase. It's a little bit of a mouthful, but just make sure that we're coding that. MDRO, multiple drug resistant organisms, will get you an extra 1 point on your NTA comorbidity category. And in this case, it's telling you that section or line item I-1700 must be checked on your MDS. And there's some different types here. For MDROs, you've got antibiotics, antimicrobial, or antimycobacterials. And make sure we're using those codes as well. We're going to do an exercise. So get your code books out. So here you have a long-term care facility resident develops a urinary tract infection during their stay, and a culture and sensitivity indicates the cause of the UTI is E. coli. This is our answer here on the screen. N39.0 for urinary tract infection, site not specified. That is our principal diagnosis. Our principal diagnosis is the infection. And when you look at that code, there's an instructional note telling you to code also the organism if known. And we do know that it was E. coli. So then we added B9620. So just be careful with that. These B95 through B97 codes can never be used as a principal diagnosis. And if you had tried that, most likely your biller would have come to you and said, this code can't be used as a principal. So just remember to check those culture and sensitivities. That's really important. That's it for the infections. Just important for you to have the knowledge that if we know what the organism is, to use the appropriate code to indicate that. We're going to move on to neoplasms. These are our C50.22 to C56.9 codes. One of the things that's important for you to understand is, how do I know if it's a current neoplasm or if it's a history of maybe they had cancer in the past? You're going to code them as current if you're actively treating the neoplasm. Maybe they're going through chemo or radiation. If it's currently being treated, pardon me, you will code it as active. Or perhaps they've gotten a diagnosis, but they haven't done anything to it yet. No treatment yet. or if they've removed the neoplasm surgically, but they haven't done any other treatment, no chemo, no radiation, you're still going to code it as current. You're going to code it as a history of a neoplasm. If we've surgically removed the site, they've completed the treatment, we have no documentation mentioning recurrence. And those codes you'll find under history, personal history codes. So you'd go to H for history, look up personal history. There's Z85 codes. And those personal history codes you can never use as a principal diagnosis. So just remember that. Some neoplasms will get you more points under PDPM, and one of those is chronic myeloid leukemia. So I want a couple of things with you. You had your table of neoplasms at the beginning of your book, and we went over that before the break. We went over what that looks like. Remember all the body sites of the neoplasms going vertically and the behavior of the neoplasm going horizontally across the top of the page. Most of your neoplasms you will look up in your table of neoplasms, but leukemia, for instance, you would look that up under L in your regular index. So just be aware of that. And that's, so you can see here to look it up, you look up the term leukemia and then chronic myeloid, and it would get you a C92 code. For this one, to get the points, it would have to be on section I-8000. Other active diagnoses on your MDS. Lymphoma and leukemia are two that you would look up by the terms. They're a little bit more systemic rather than, you know, a tumor or a neoplasm. Also, myelodysplastic syndromes and myelofibrosis is another NTA comorbidity that will get you 1 extra point. Again, also has to be on section I-8000 of your MDS. A lot of these are going to be D56 codes. That mapping tool that I showed you earlier, the one I said don't print, where you can look up all your clinical coding categories, you can look up all the codes that would possibly get you NTA points on that tool as well. Laryngeal and oral cancers are SLP comorbidities. So again, those cancers for malignant neoplasms, I should say. So that will get you extra SLP points. Again, you would have to code that on section I-8000 of your MDS. Should also be on your diagnoses list. But these only apply to primary malignancies for you to get that SLP comorbidity. Here we're going to do another exercise. This one's more involved. Let's review this together. We have a resident who's admitted to your facility for hospice, and they have a diagnosis of history of cancer of the lung with brain metastasis. So that means they had cancer of the lung and it spread to their brain. They also have a history of a right lower lobe pneumonectomy. So they removed part of that lung, and chronic anemia due to the cancer, due to neoplastic disease. So work on this, assign all applicable codes, and I'm going to pull up a poll in a few minutes, and I only want you to click on the one you would assign as your primary diagnosis. Work on the other ones. I'll give you time to work on that, but only click on the one that would be a primary diagnosis, and the poll will pop up and there it is. So work on that, give yourself some time to work on that. We'll go over all the answers and I'll give you 10 minutes. So the principal diagnoses would be C79.31 metastatic of the brain. And the rationale for why we have this code as a principal would be the resident no longer has lung cancer. It is now spread to the brain, and the brain malignancy is a reason for them receiving hospice care. Therefore, we're going to sequence it first. Next. Then for our additional codes, we have D63.0 anemia and neoplastic disease. We do know that the physician has documented that the anemia was due to the cancer, the neoplasm. And then Z51.5, encounter for palliative care. They are admitted for hospice care. True, but this code would not be an appropriate principal diagnoses. So when it comes to hospice, just remember this. The reason for hospice will always be your principal diagnoses. You do want this Z51.5 encounter for palliative care as a secondary diagnosis, true, but it should not be your principal. Next. And then, of course, we should also make sure that our claim is thorough and it shows everything that's going on with the resident. They did have a history of lung cancer, but they were removed. It's no longer present. We still would want to show that. And we would also want to show that they did have a pneumonectomy prior to them coming to us. So that's why we would use Z90.2, acquired absence of the lung or part of the lung. Next. We're going to move on to endocrine, nutritional, and metabolic diseases. These are our E codes. So mainly when you think about this particular chapter, you think of diabetes. Now remember, there are 5 different types of diabetes codes. That's quite a bit, but the main one that we're going to be using is for type 2 diabetes. But you can see here we have E08 for underlying condition, E09 for drug or chemical induced, E10 for type 1, E11 for type 2, and E13 for other specified. If the documentation doesn't tell you the type of diabetes, the default one you're going to use is type 2 because that is the most common type of diabetes. Next. So earlier in the morning, we were talking about conditions that are presumed to be related. And one of the ones we were talking about was diabetes and diabetic combo codes. So remember, the classification assumes a cause and effect relationship between diabetes and certain diseases. So remember, chronic kidney disease, neuropathy, there's a bunch of them. So anytime you see a code that says diabetes with, and then another condition, just know that if both conditions are documented, that they are presumed to be related to the diabetes. Unless the physician specifically says it's due to something else, you will assume it's related to the diabetes. Now, the default code for diabetes when you're looking it up is E11.9. That's diabetes without complications. Just be careful that you're not using that if they do have a diabetic manifestation. So don't use that if they have any complications. Next. Diabetes with PDPM. So we'll map you into the nursing special care high section if they have insulin injections for all 7 days and insulin order changes on 2 or more days. And those would be documented in section N of the MDS. Next. We also have some comorbidities, NTA comorbidities when it comes to diabetes. So if they have diabetes with a foot ulcer, that will get you an extra point. That would have to be checked off on section M of the MDS, but we should also use that diabetes with foot ulcer combo code as well. And then, of course, diabetes with retinopathy. And there's 2 different types here, diabetic retinopathy and vitreous hemorrhage, and proliferative diabetic retinopathy with vitreous hemorrhage. Diabetes and diabetic retinopathy will get you another point. Next. Now, if you have somebody who has diabetes, they could be treated with insulin or with oral meds. We do want to code either. If they're using one or the other or either, you want to code them all. So if they have type 2 diabetes or basically any sort of diabetes except for type 1, you're going to code the use of insulin and oral hypoglycemic drugs. And those are Z codes. And again, those won't be high on your diagnoses list. They'll be towards the end. Next. Morbid obesity or obesity codes. These are, it's important to code obesity with our Medicare Part A's because Some obesity codes will get us more points, but remember, we have to have that documented by the physician. To code obesity, that has to be documented by the physician. But if you have a resident who comes in and, you know, they're 5'3" and 500 pounds, and your physician has not documented obesity, but it's apparent that they are morbidly obese, you would want to query the physician, and that query tool should be part of the packet that was provided to you today. But just remember, when it comes to BMI, you only code that as an addendum or an add-on to an obesity code, or maybe a malnourishment code. Next. So morbid obesity will get you 1 point on NTA. You have to code it under section I-8000. Pardon me. There's 3 options for scoring you into this NTA category. If they have a BMI of 40 or greater, that code will map you into that category. It's a Z68 code. Or the code for morbid obesity will map you into that category. And the code for obesity with hypoventilation syndrome, E66.2, will map you into that category. So any of those 3 will get you there. So just be aware, sometimes you have a physician who documents that a resident has morbid obesity, but perhaps you know, their BMI is less than 40. That doesn't mean you can't code morbid obesity. If they document morbid obesity, you want to code it. Sometimes your physician will document morbid obesity. Maybe their BMI is less than 40, but they have, you know, diabetes, they've got sleep apnea, they've got some other sort of comorbid condition that would lead them to use that code. Next. Malnutrition is another diagnoses that will map you into an NTA comorbidity category. It will get you 1 point. You want to be careful with coding malnutrition. You know, if they're at risk for malnutrition, maybe they've got a really low BMI, they've lost a lot of weight, you have to have the physician documentation that malnutrition is indeed present. So be very, very careful with that. Now, if you see somebody with a BMI less than 20, though, and it's not documented, and they've got, you know, your RD is telling you it looks like they're malnourished, you would want to query your physician. And also in that packet that you received is a malnutrition query for your physicians. So again, you can't code it unless it's documented by the physician. So just be aware of that. And the physician would have to fill that out and sign it in order for you to code it if it's not already documented. Next. IV feedings. If you have somebody who is receiving nutrition, you know, whether it's subcutaneous or through IV, that will get you more, I don't want to say points, but it will map you into the nursing special care high category. And those are checkboxes on section K of your MDS. So just be aware of that, and you want to code the reason why they are receiving the IV feeding. Next. Cystic fibrosis is a code that will get you 1 point on your NTA comorbidity category. Those are pretty straightforward. And those codes would be on section I-8000 of your MDS. Next. We're going to move on to mental, behavioral, and neurodevelopmental disorders. These are your F codes. Dementia. There's 3 different types of dementia, but the first one we'll review quickly is vascular dementia. So this is usually as a result of some sort of brain infarction due to vascular diseases, such as hypertensive cerebrovascular disease. If they have some sort of physiologic condition or sequela of cerebrovascular disease, there is an instructional note telling you to code first that physiologic condition. All of your dementia codes will have with or without behavioral disturbance. So you have to check your documentation. Well, the physicians I have noticed are getting a lot better about coding, or I should say documenting with or without behavioral disturbance. But just be aware when we're talking about behavioral disturbance, this would be somebody who's aggressive, combative, violent, or they're wanderers. Next. F02 dementia codes is dementia in other diseases classified elsewhere. These are the dementia codes you're going to use when you have somebody who has an underlying documented reason for the dementia. Maybe they have Alzheimer's or MS or Parkinson's. So remember earlier we were talking about what gets coded first. So the underlying reason will be first. So your Alzheimer's would go first, and then your appropriate F02 dementia code would come after that. And again, with or without behavioral disturbance. When we're talking about behavioral disturbance, we are not referring to depression, and we're not referring to anxiety. We're referring to, again, aggressive, combative, violent, wanderer, those sorts of things. Next. And then F03 is for unspecified dementia. So same qualifiers, you know, with or without behavioral disturbance. And if they have wandering, just remember there is a code for that, Z9183. Next. We had some changes here for fiscal year 2022 for depression. So as of October 1st, the default depression code is no longer F32.9, it is F32.8. I'm sorry, point A, F32.A, depression unspecified. That includes depression not otherwise specified or depressive disorder not otherwise specified. So most of the time you end up with a code like this, not otherwise specified when it comes to depression. I would encourage you to look at, if they're seeing a psychiatrist, to take a look at those psychiatry notes. If they are coding, or I should say documenting to a higher specificity, that's where you're going to find that. Next. And then for substance use, abuse, or dependence. So if your physician says that you have a resident who is using a particular substance, abusing, or dependent upon a particular substance, there's a hierarchy to it. So if they say they are using and abusing methamphetamine, you would code abusing methamphetamine. And if they're saying they abuse and are dependent, use the code for dependence, so on and so forth. Just think, if they're giving you two options, code the more severe of the two options. Next. And medical conditions that are due to use, abuse, or dependence are not classified as substance-induced disorders. So you want to, if they're telling you that they have a medical condition as a result of the use, abuse, or dependence of a substance, code the condition separately, and then code separately the use, abuse, or dependence code. Next. So they've changed the guideline to say that psychoactive substance use codes are to be only used when the substance use is associated with a substance use disorder or a medical condition, which is documented by the physician. So again, code the medical condition along with the appropriate psychoactive substance use, abuse, or dependence code. And we have an example here of alcohol-induced acute pancreatitis. That's a condition, coded first. And then we also would code alcohol dependence in addition. Next. If you see somebody or a physician documenting history of alcohol or drug use, that's the equivalent of in remission when you're looking up the codes. You're going to look up the codes for in remission. Next. We'll move on to diseases of the nervous system. These are RG codes. Pain, category G89, you can code pain as a principal diagnosis when the pain management is the reason why they're being admitted. And then, of course, your underlying cause of the pain, you want to code that as a secondary diagnosis. Chronic pain, when it comes to chronic pain, we don't have hard and fast rules for a time frame for defining when pain becomes chronic. It really just depends on what your physician is documenting. So if your physician documents they've got chronic pain, you can then assign a code from category G89.2. Next. Neoplasm-related pain, this is where somebody has cancer and they have pain, related to the cancer. Whether the pain is acute or chronic, if it's related to the cancer, you would assign code G89.3. And again, if they are admitted for pain management or pain control due to this pain related to the cancer, you can use it as a principal diagnosis. And just remember that code will also ask you to code the neoplasm. So you would need to code the neoplasm in addition. Next. Chronic pain. So G89.2 is the code for chronic pain, but we also have codes for central pain syndrome, G89.0, and chronic pain syndrome, G89.4. So be very careful when you see syndrome codes. Only code chronic pain syndrome if your physician documents chronic pain syndrome. If they just say they have chronic pain, again, it would be a code from G89.2, but if they say chronic pain syndrome, G89.4. And again, only use it if the physician has documented it. Next. ALS is considered a speech and language pathology comorbidity, and that would have to be coded on section I-8000 on the MDS, and it's code G12.21, and also on your regular diagnoses list. Parkinson's will impact your nursing category for nursing care low. That would be a checkbox on section I-5300 on the MDS with a nursing function score below 11. And you would need to have code G20 on the diagnoses list as well. Next. MS, multiple sclerosis, that impacts two areas. So your NTAs, comorbidity category, again, that would be checkbox I-5200, and it also impacts your nursing special care low. So that impacts two case mixes. So you want to be careful when you're coding that, make sure it's accurate. And it's a G35 code that would have to be on your diagnoses list, as well as your MDS. Epilepsy. So when it comes to epilepsy or a seizure disorder, because when it comes to coding, those terms are used interchangeably, it is an NTA comorbidity if it is intractable, documented as intractable. Intractable means it's poorly controlled. So if you have a resident who has a seizure disorder and they're on regular meds and then they're having breakthrough seizures and you're having to send them out, that would be intractable. And those codes for intractable seizure disorders will get you 1 NTA point. And that would be on section I-8000 of your MDS. So just make sure you're checking your documentation for that. We also have code R569 for convulsion not otherwise specified. Do not use that code if seizure disorder or epilepsy is documented. That's just the convulsion. So we don't want to use that for somebody who has documented seizure disorder. A lot of times that R569 convulsion code, I would expect to see that for somebody who's maybe had some sort of surgery on the brain and they're giving them prophylactic medication to prevent seizures, then I might expect to see that code used in that particular case. Next. Narcolepsy and cataplexy. So those are neurological conditions that affect sleeping and staying awake. That will get you 1 point on your NTA comorbidity category. And again, that would have to be on section I-8000 of your MDS. And a lot of times you'll see that they're taking a medication for that. Next. Cerebral palsy will affect your nursing category. And again, even though we're checking that off on the MDS, we still would like to see that code from category G80 on your diagnoses list. Next. Hemiplegia and hemiparesis will impact your nursing category. Those are considered clinically complex. Now, there are two different types of hemiplegia or hemiparesis codes. Some of them are from category I-69 as a sequela of a CVA or a cerebral hemorrhage. So if somebody has a stroke and as a result of that stroke, they have hemiplegia, you would assign a code from category I-69. But if you have a resident who has hemiplegia, but we don't know what causes it, you would use a code from category G81. And just know that either one of those codes from either category will map you into the nursing clinically complex category. But we want to be accurate. Even though both will map you there, you want to make sure that you're assigning the code that matches the documentation. Next. Quadriplegia will map you into a nursing special care high category. That's a checkbox on the MDS, but we also want to make sure that we have a code from category G82 on the diagnoses list. Now, when we're talking about mapping into the nursing category, we are referring to true quadriplegia, which is a paralysis of the limbs caused by a spinal cord injury. Functional quadriplegia does not map us into that category, so just be aware of that. Next. So here's a change to the clinical category for anoxic brain damage. So one of the things we look for every year in our updates is what changes have they made to help us out, and this is a good one. So prior to October 1st, G93.1 anoxic brain damage was a return to provider code, which is unfortunate, right? We want to get reimbursed for this. But now it maps to acute neurologic. Next. So why did CMS make those changes? Well, they made the changes because they're saying, you know, somebody who has anoxic brain damage would most likely need care, long-term care. And, you know, they switched the map to acute neurologic for that reason. So just be aware of that. That's a good change. We like to see good changes like that. Next. We have a brand new code. And I say brand new, meaning we've had it since October. But G44.86 is a cervicogenic headache. So that's referred pain. So it's usually perceived in the head from a source on the neck. So I don't know about you all, but have you ever had tension in your neck and then bam, you've got a headache? Well, there's a code for that now, cervicogenic headache. Next. Other toxic encephalopathy has a new code. So this includes toxic encephalitis or toxic metabolic encephalopathy. It used to just be G92. Now they've expanded it to G92.8. And if it's due to a poisoning from a drug or toxin, you need to assign the correct code from the table of drugs and chemicals. And if there's any additional code for adverse effects, you need to code that as well. Next. And then G92.9 is unspecified toxic encephalopathy, and the same coding instructions apply as the prior code for G92.8 for poisoning due to drug or toxic or adverse effect due to drug or toxin. Next. We're going to move on to diseases of the circulatory system. So I codes, hypertension. So I-10 is the code for essential hypertension. That means they have no chronic kidney disease and no heart disease. So if they have no heart disease, no CKD, but they have hypertension, you would use code I-10. Then the next category is I-11, hypertensive heart disease. And again, that is if they have hypertension and heart disease or hypertension and heart failure. So I-11.0 is hypertensive heart disease with heart failure, meaning they have CHF. And you will see when you assign that code that it's going to tell you, don't forget to also assign a code from category I-50 to indicate the type of congestive heart failure. But they can also have I-11.9, hypertensive heart disease without heart failure. That means they have hypertension and one of the listed heart conditions that you see here. And that means codes from I-51.4 to I-51.9. So that includes myocarditis, myocardial degeneration, myocardial disease, cardiomegaly, Takotsubo syndrome, carditis, or pancarditis. Any of those. What you don't see here is coronary artery disease. That's a common boo-boo I see. They say, oh, they've got coronary artery disease and they've got hypertension, so therefore I should use a code from category I-11, but that's not correct. Only the codes that you see here, I-51.4 to I-51.9 and hypertension. Next. Then we have I-12, hypertension, kidney disease, and this is if they have hypertension and CKD, chronic kidney disease. So you can see I-12.9 would be hypertension with stages 1 through 4 or unspecified CKD. And then I-12 for if they have hypertension and then they have end-stage renal disease, meaning they're on dialysis. That code will, any of these codes, I should say, will also have an instructional note saying, use an additional code from category N18 for the stage of the CKD. So even though it's a combo code, right, it's hypertension with chronic kidney disease, you still have to use an additional code to further specify the stage of the CKD. Next. And then I-13 is if they have all three, hypertension, heart disease or CHF, and chronic kidney disease. And there's a few of those, but basically it's going to tell you to also code the type of CHF and the stage of CKD. And then I-15 is if they have secondary hypertension. So they're going to document hypertension due to some other medical condition. And that's when you would use a code from category I-15. Next. Acute myocardial infarction. We have a couple of different types. Initial acute myocardial infarction, type 1, meaning they had a heart attack within the last 4 weeks or 28 days. And then you have codes I-21.A for myocardial infarctions types 2 through 5. And this might, this seems a little bit crazy, but I-20.2 is old myocardial infarction. Anything greater than 28 days ago is considered an old myocardial infarction. So just be aware of that. Next. Coronary artery disease. Your default CAD code is I-2510. How you look these up, you would go to the main term disease, then artery, then coronary, and it would get you I-2510. If they document that they have angina and coronary artery disease, you're going to presume that they're related, and you're going to use a combo code. So you can see a couple examples here. I-25-110 is unstable angina, and I-25.119 is unspecified angina. So again, coronary artery disease and angina, if they don't have a CABG, if they haven't had a coronary artery bypass graft, you're going to code them as from this category, and you're going to code them as related. Next. Endocarditis is an NTA comorbidity. They'll get you 1 point, and it would have to be on section I-8000 of your MDS, and there's a lot of different types, so you'd have to use your NTA mapping tool to find out which ones will map. Next. Cardiorespiratory failure and shock is an NTA comorbidity category. Get you 1 point. Again, section I-8000 of your MDS. These include cardiorespiratory failure codes, both, and it includes your chronic respiratory failure codes. Next. Heart failure. So you can see we've got quite a bit of different categories for heart failure. Left ventricular failure, systolic, diastolic, combined systolic and diastolic, other heart failure, or unspecified. So just make sure that you're looking at your documentation to get you the best code. Next. We do have a little bit of guidance when it comes to coding CHF. If your physician has documented the ejection fraction, that can help you. So if they say that they have heart failure with normal or preserved ejection fraction, you can interpret that as diastolic. If they say they have reduced ejection fraction, you will interpret that as systolic heart failure. And if they say combined systolic and diastolic left ventricular, or heart failure with reduced ejection fraction and diastolic, that will be considered combined, both of them. And you would assign a code from category I-50.4. Next. Sequela or late effects of cerebrovascular disease. So when we have somebody who has a stroke, they go to the hospital first thing, right? We don't, take them directly to the skilled nursing facility. We take them to the hospital. The hospital treats the acute stroke. When they're all done at the hospital, right, they've done everything they can for the acute stroke. If they have late effects or sequela, that is what we treat at our skilled nursing facilities. So just be careful that you should not be assigning codes from categories I-60 through I-67 because those are acute CVA codes. We should only be assigning codes from category I-69 because we only treat the late effects. Next. So how do we look those up? There's a couple of different coding paths. If your physician documents that they had a hemorrhage of some sort, subarachnoid, intracerebral, etc., then you're going to start with the term sequela. Always the term sequela in your alphabetic index. Then you would look for the subterm hemorrhage. And then your next subterm would be what type of hemorrhage? Subarachnoid, intracerebral, intracranial. And then you would look up what is the late effect. Is it hemiparesis? Is it dysphagia? What is it? And then that would help you get your code. Now, when it comes to CVAs, you start with the same main term, sequela. Then the next subterm is infarction. And then the next one is cerebral. Then your late effect, hemiparesis, what have you. And that's how you get your codes. Next. When it comes to coding somebody who has hemiparesis or hemiplegia or monoplegia, etc., we have some defaults for, they want to know what side is affected. Is it their dominant side or non-dominant side? So for instance, I am right-handed. If I had a stroke and my right-hand side was affected, they would say it's my dominant side. But if my left side was affected, they would say non-dominant. These are the defaults. If we don't know if somebody is right-handed or left-handed, they're going to go with the most common. So again, if the left-hand side is affected, they're going to say non-dominant. If the right-hand side is affected, they're going to say dominant. But I guarantee you, your therapy is asking them, are you right-handed or are you left-handed? They want to know because that's very, very important to them when they're doing their care plans and they're trying to help our residents out. Next. Again, for hemiplegia and hemiparesis, this impacts our nursing clinically complex, and either one will map you into this category, whether it's an I-69 code or a G81 code. Either one will map you. Next. So we have some SLP comorbidities from this section. And this slide just kind of tells you where you're going to check those off on your MDS. So if they had a CVA, a transient ischemic attack or TIA, you're going to check off from section I-4500. Hemiplegia would be I-4900. Dysphagia and apraxia would be I-8000. Aphasia, I-4300. And any speech and language deficits would be MDS section I-8000. Next. DVTs are found in category I-82 in your book. So these codes will be 6 characters long. Your 4th character will specify whether it's an acute or a chronic DVT. The 5th character will tell you the affected vein. And the 6th character will tell you the laterality. So if you want to look up a DVT, you would start with the main term embolism, and then the vein, and then chronic and the affected veins. History of a DVT, and we are giving them prophylactic medication, then you would use code Z86.718, personal history of other venous thrombosis and embolism. And you would not code that high, and you definitely could not use a history code as a principal diagnosis, but you would want to put it on your claim. Next. Okay, we're going to do another exercise. A resident is discharged from the acute hospital and admitted to a long-term care facility after they had an acute CVA with left-sided hemiparesis and oral phase dysphagia. So I'm going to give you 10 minutes to do this one, and then you would select your answers on the screen. It should be one answer. So select that once you've done your work, and I will give you 10 minutes, and we'll come back and we'll take a look at the results. So your principal diagnoses should be I-69.354, hemiplegia and hemiparesis following cerebral infarction affecting the left non-dominant side. Now, one of the questions that we got was, how do we know if they are right or left-handed? We don't. And that's pretty common. We're not going to know a lot of the times. If therapy's involved, we can ask them, but in this scenario, we don't know. And then for additional diagnoses, we also used code I69.391, dysphagia following cerebral infarction. That code asks you for an additional code for category R13 to delineate the phase of the dysphagia. So in this case, we knew it was oral phase. Next. So remember, the hemiparesis and the dysphagia are considered to be sequela or late effect of an acute CVA. So that is why we were using the codes from category I69. Next. Now, one of the things that you need to be aware of is there is a problem with the clinical category mapping for long-term care. I-63-9 is the code for cerebral infarction unspecified, and you can see that it maps to acute neurologic. So if you were to assign the code for cerebral infarction or acute CVA, it's going to let you. And you're going to say, oh, look, it maps. But remember, we are instructed by Medicare to use the coding guidelines. So even though it does map, we should not be using an acute CVA code because we're not treating the acute CVA. So just be aware of that. Next. Okay, let's move on to the next one. And we're going to move on to respiratory diseases. So these are your J codes. Now, pneumonia will impact your nursing category. So if you have pneumonia with a fever and you select box J1550A, fever plus pneumonia, on your MDS, it will map you into nursing special care high. But if it's just pneumonia, no fever, that will map you into nursing clinically complex. Next. So a lot of times I like to say, hey, what's the code for pneumonia? I'll ask somebody, and their first thing out of their mouth is going to be J18.9. True, that is the default pneumonia code. So when you look at pneumonia in your alphabetic index in your code book, it's going to say J18.9, which is pneumonia unspecified organism. But as you can see on the screen here, we have a lot of different types of pneumonia. J12 for viral, J13 for strep, etc. Pay attention to the last bullet point here. J69 is pneumonitis due to solids and liquids. That is the code for aspiration pneumonia. And it's actually pneumonitis. It's an inflammation. It's not an actual pneumonia code. So just to be aware of that. And if you know what the organism is, use the correct combo code. So just be aware of that. Next. Asthma, J45 codes. we have a bunch of different types. We have mild intermittent, mild persistent, moderate persistent, severe persistent. There's quite a few asthma codes. However, most of the time we don't have that information. So just to be aware that if they see a pulmonologist, that's where you're probably going to find that information. And your fifth character on your asthma codes will tell you if it's uncomplicated asthma with exacerbation or status asthmaticus, which is an emergency. Probably you're not going to see that. Next. Pulmonary fibrosis and other chronic lung disorders will get you 1 NTA point, and they would have to be checked off, or I should say added to section I-8000 of your MDS. And there's just some examples here of some of the ones that would fall under that category: pulmonary fibrosis and other interstitial pulmonary diseases from category J84, bronchiectasis, chronic lung disorders, and other respiratory disorders and diseases classified elsewhere. Next. COPD, chronic obstructive pulmonary disease. Those are codes that you'll find under category J44, and those include asthma with COPD, chronic bronchitis with emphysema, and chronic obstructive bronchitis. Those all fall under that category. Next. Okay, so one of the things I wanted to make you aware of is this particular guidance for coding somebody who has COPD with concurrent pneumonia. So coding clinic guidance for COPD with pneumonia is as follows. If you have somebody who has COPD, chronic obstructive pulmonary disease, and they have an active case of pneumonia, you should assign code J44.0 COPD with lower respiratory tract first as your principal diagnoses, and then also code the pneumonia as a secondary code. Now, just know that aspiration pneumonia is not part of this. It's not included as a lower respiratory tract infection. So if they have COPD and aspiration pneumonia or pneumonitis, you would not have to follow this guidance. So just be aware of this. Next. Asthma, COPD, and chronic lung diseases will get you more points on your NTA comorbidities and can impact your nursing special care high if they have shortness of breath while lying flat and any of these diagnoses, asthma, COPD, or chronic lung diseases. But just be aware, if they have COPD and they have shortness of breath while they're lying flat, that is a nursing category PDPM qualifier. So ask yourself, is there supporting nursing documentation of them having shortness of breath while lying flat? That might require a little bit of a closer look on your evals and your documentation. Next. Here's our next exercise. A resident is admitted with pneumonia caused by Klebsiella pneumoniae, and they also have a diagnosis of COPD and anemia. So I'll give you 10 minutes for this one, and then we'll come back. Make sure that you're when you've done your work and you want to answer it on the little poll pop-up, please. So your principal should have been J44.0, chronic obstructive pulmonary disease with acute lower respiratory infection, followed by J15.0, pneumonia due to Klebsiella pneumoniae, and then D64.9 for unspecified anemia. And this whole exercise was to bring home that slide about how to code COPD with pneumonia. Remember, if they have COPD and an active pneumonia case, we want to use J44.0 COPD with an acute lower respiratory infection. Then we also need to code the pneumonia, and we have a combo code that tells us pneumonia due to Klebsiella. So we've got nice combo code. And then anemia, we didn't know what type of anemia, so we use D64.9 anemia unspecified. Next. So again, just driving home that coding clinic guidance for coding COPD with pneumonia. Next. We're going to move on to the next section, digestive system, inflammatory bowel disease. Just be aware that this codes from this category will get you 1 comorbidity point. So these include things like ulcerative colitis and Crohn's disease. Next. Cirrhosis of the liver, end-stage liver disease will also get you 1 NTA point. And these codes would have to be on section I-8000 of the MDS. So these are your codes from case 70 to case 76. Next. Chronic pancreatitis will also get you an NTA point. Next. And GI bleeds. Let's talk about GI bleeds. If we don't know what region the hemorrhage is going on or the GI bleed, you will end up using code from category K92.2. And that one has an excludes one if they have acute hemorrhagic gastritis, a hemorrhage of the anus or rectum, diverticular disease of hemorrhage, gastritis and duodenitis with hemorrhage, or peptic ulcer with hemorrhage. And the reason for that is all of those codes I just mentioned are highly specific, and K92.2 is an unspecified hemorrhage code. Next. And we have a change to the PDPM clinical category for esophagitis codes if they have bleeding. So you can see K20.81 is other esophagitis with bleeding. K20.91 is esophagitis unspecified with bleeding. K21.01 is GERD with esophagitis with bleeding. So as you can see, the PDPM clinical category for these, it used to be return to provider. Now they've changed to medical management. Next. So why did they change it? The rationale for that is because of the bleeding, they're more likely to be found in SNF patients. So that's why they've switched it to medical management so that the clinical category assignment's a little bit more accurate. Next. Okay, we're going to move on to questions. Okay, so I have a question here from Bernadette. Are we going to provide us with a copy of the slide? I believe that will be emailed to you, the handouts. And the other question is, can I still use the mapping tools I have, but not the 2022 version? So I'm not sure if you're saying you're using the 2021 version, that will not be accurate. Make sure you go to the CMS website. You can search for clinical PDPM clinical category, and it will bring you up the clinical category mapping tools, and make sure you're downloading the correct one for 2022 so that you have the correct version, because you can see we already went over a few different scenarios where they've changed how things map. Remember that there was a brain injury, anoxic brain damage, that one's been changed. And then these esophagitis with bleeding ones, those have changed too. You want to make sure that you have the most current one being used. The next question I have is from Susan Johnson. And her question is, medical records make queries to doctors? Absolutely, medical records can make queries to physicians. It's definitely something you want to do if we're not clear. And what we don't want to do is have a leading query. And tomorrow we're going to go over physician queries in more detail. Part of your packet that you'll get, or maybe you have already received, will be some physician queries, some sample physician queries, and you can see how those are outlined and how you would want to do that. But yes, definitely medical records can make queries to doctors, provided they're doing it correctly. And then the next question is also from Susan. Is there a best practice timeline of when a fracture is considered history as opposed to current? That one's a little bit difficult to answer, but what I will say is this. If they've just come to you from a hospital admission, and the reason for that admission was a fracture, and they're coming to you for therapy and for healing. Because of that fracture, you definitely want to code it as current. I usually don't waste my time putting codes for history of traumatic fracture. I don't usually bother with that. You can, but I'm only going to code the fracture if it just happened during that admission or we're treating it. Sometimes you'll see documentation that has to do with, there's a fracture and its acuity is kind of undetermined. If we're not sure, we should query our physician and ask them to make that clear. But remember, the RAI manual's description says that they have to be a physician documented within the last 60 days. So, take all that information together and make your best choice. Let's see. Oh, here we go. We have some more. Okay, if the patient is admitted with UTI and has already resolved in the hospital, can we still code it in section I-2300? Okay, so that has to do with the MDS, and the MDS has very specific rules for coding UTIs within the last 30 days. They look at different criteria for that. So follow the criteria for your MDS for coding UTIs. Just be aware of that. And then somebody says, oh, Bernadette saying, resident has a UTI recurrent. Can I code again or just change the new date? Can I code again or just change the new date? Well, if the prior one had resolved, we would have taken it off and put it on with a new date. So the date should correspond to the start of treatment. If H&P says aspiration pneumonia, do we use J69? Yes, you would use an aspiration pneumonitis code for that. Absolutely. And Patricia wants to know, are we going to discuss sequencing of codes? Yes, absolutely. We've done it a little bit here, talking about, what you would select as your principal diagnoses and what your secondary codes will do. But tomorrow, we are definitely going to get into sequencing of codes, particularly for PDPM. Then the next question I have is for a GI bleed. When the patient comes from the acute with a GI bleed, are we supposed to code this diagnosis? Isn't this an acute problem? If it's still something that we're monitoring or we've taken steps for, maybe the doctor's changed the medication, you could code it. It just depends. It depends on the scenario. And I believe that might be it. Bernadette says, thank you. I learned so many things. Bernadette, thank you so much for being patient with the problems we had with the computer today. I'm not sure what's going on, but crossing fingers that tomorrow it will be a lot better and smooth. Let's see, we have another one. Now, Susan says, patient is admitted post-CVA, but no, even after consulting therapy. What would you code? Well, I would hope they have some other sort of skilled coverage, skilled conditions that we could code. Sometimes it's just fatigue, or they're just kind of you can query your physician. You can use that query tool for unspecified or kind of unknown principal diagnoses to get more clarification. But I wouldn't, just code anything. I'd be very, very careful with that one. There is a code Z86.73 for history of CVA without sequela. However, you can't use that code as a principal diagnosis, so just be aware of that. And Patricia says, for palliative care, I want to clarify if we need to code first the reason for palliative admission. Yes, 100%. So we did a scenario earlier, Patricia, where we had somebody who had, I believe it was cancer. So the reason for the palliative care was the cancer, and then your secondary code would be Z51.5 and counter for palliative care. That Z51.5 code should not be a principal. It should be a secondary code. And rehab and medical records should be as a team for PDM. Absolutely, Bernadette, 100%. And that is why one of the first things we talked about this morning was what the best practice is for coming up with the principal diagnoses. And we were suggesting the day after admission that we look at that record together and we determine what is the principal diagnoses. And we give that code to therapy. They should be part of that process, but they should have that code or codes for their evals so that they're accurate. And that way everyone's documentation is on the same page. And let's see if we have any other questions. Any other questions? Okay, I don't see any more. We're, a couple minutes away from 12 o'clock. So I'm going to say thank you so much for your time today. And we will be back tomorrow at the same time. If you do think of any questions later on today, write them down and you can enter into the chat box tomorrow and we can go over that tomorrow. But meanwhile, thank you so much and have a great day and take care and stay safe.